look, I'm getting these really funny heartbeats. Oh, that's anxiety.
Other aspects of lifestyle which may be relevant.
Be patient with yourself and just build up gradually.
So I just needed to have them work with me.
There's a whole bunch of cardiomyopathies.
Benefits of doing genetic testing.
Take their own heart monitor. There's better types of fat.
Try and find a cure for inherited heart muscle diseases.
So there's a narrative which runs throughout the whole day, hopefully, in the 3 talks I'm giving. And this one's about personalised medicine. So these are my complex ones. This doesn't mean I have a Ferrari parked outside. But in a way, it does represent an incredible change in cardiomyopathy land. Because 10 years ago, or 5 years ago, industry was not interested in cardiomyopathy. And now they're all over it. And this is what's going to drive, I think, a whole new era in the treatment of these diseases. You can't go anywhere, can you? Without, it's almost as bad as AI. You know, every news article is about AI or personalised medicine. There's a bit of a debate as to what that really means. Yet this kind of thing is done by people that have never seen, touched, or heard a patient. You know, robotics, the Internet of Things, whatever that might be. You know, yes, it's emblematic of the incredible advances we have in knowledge, in technology, but it isn't very real to someone sitting in a clinic. This is a bit of a wordy definition. There are many, many definitions for personalised medicine, but it's basically what is the cause of disease in this individual, and can I tailor my therapy more specifically to that person's condition? And this is a thought process which has actually probably for 10, 20 years been evolving in oncology, in cancer medicine. The traditional way of treating cancer is to say you have a particular cancer, we're going to give a therapy, and in the hope that everybody's going to respond in the same way. But of course we know that's not true. Some people will respond, some people it will be ineffective, and some people you'll make sicker. The basic principle underlying personalised medicine is you say, okay, well, a cancer diagnosis is not a single disease, it's actually a range of different diseases. And if we can optimise therapies for those different subgroups of disease, we can get a more homogeneous, a more even distribution of responses. Now, in cardiology, God, it seems like a long time ago now, doesn't it, 2018? This was an article about personalised medicine in Nature, recognising that this was here to stay, but personalised medicine has yet to make much headway in the treatment of cardiovascular disease. Now, I show these slides, to meetings, cardiology meetings all over the place, and often you can see a sort of bristling. How dare you say I don't do personalised medicine? Because, I can image the heart in 1,000 different ways. I can make diagnoses of inflammation, amyloidosis, excessive iron, blah, blah, blah. That's ultra-personalised. We can do 1,000 things to the heart. We can give drugs, we can give anticoagulants, we can ablate arrhythmias, we can give a whole range of different drugs, we can stitch the mitral valve together on a catheter. Surely that's personalised medicine. It's complex medicine, but most of it is treating the consequences of disease. And it doesn't really come very close. That's a word which we use all the time in medicine, which basically means cause. What is the underlying driver for the disease, and are we targeting it? And again, I come back to this example of oncology. So this slide, all these different acronyms here refer to different subtypes of lung cancer. So lung cancer is not one disease. It's a family of different diseases. And what you see on here, this is already out of date, is that each of these boxes is a new anti-cancer drug being licensed in the United States. Almost one a month.
Is that just for lung cancer?
No, this is from different kinds. So some of them are breast, some of them are blood. No, but what these are all doing is they're targeting specific molecular signatures that we see in different cancers. So this is a cardiomyopathy conference. Now, in a way, cardiomyopathy is very similar to the rest of cardiology. We've had a very simplistic way of describing it. We describe what we see. So a cardiomyopathy is a bad heart, which isn't explained by high blood pressure, valve disease, or coronary disease. And then we take that and we say, well, if it's thick, we call it hypertrophic. If the heart's baggy and doesn't contract very well, we call it dilated. It's not really very personalized, is it? And we, as we were discussing this morning, I'm sure in some of the other talks as well, we realized that each of these different groupings summarizes families of disease, often genetic, caused by mutations in genes that affect all parts of the cell. The genetics is complex. It may be about a single spelling mistake in a gene. It may be what we call polygenic effects, where it's the net result of inheriting maybe 10 or 20, 30, 40 different variations in a gene. It may also be because you've got obesity or high blood pressure or sleep apnea, or you've got inflammation in your heart. It's complex. Now, so this is a version of what I give at cardiology conferences. And certainly for quite a long while, it was probably my own paranoia, but I'd look around the room and I'd be seeing this sort of thing. I want you to feel sorry for me. Because cardiology doesn't work this way. Probably very few of you have heard of this man, but Eugene Brownwald is sort of this giant in cardiovascular medicine. He's about 300 years old now. I'm not sure how old he is, but this was his list of advances, what he regarded as being the big advances in cardiology over the past 30, 40 years. ECG, cardiac catheterization, surgery, angiography. You'll see that most of this is about technologies, about techniques, ways of interrogating what the heart is doing. Of course, you've got things like cardiovascular drugs, and there's been no doubt we've had huge advances in management of heart failure, for example, with ACE inhibitors, beta blockers, dapagliflozin, et cetera, et cetera. But then echocardiography, pacemakers, is very technology-based. We feel good as cardiologists because we're driving down mortality from cardiac disease. Well, that's the story we've been telling. And it's sort of true, except that most of this is probably nothing to do with all the things I've just shown you. Most of it's due to the fact that we're trying to stop people from smoking, we're trying to get them to live more healthily. It's about preventative measures in a population level. I say heart failure, we think we're doing good because we've got lots of drugs, lots of devices. But from the wilderness, the prophets of cardiomyopathy, what we've said is, but within the noise of heart failure, there are individual stories that we've been missing. So let me give you a couple of examples. And I sincerely hope that these cases are not sitting in the audience. If you are, I apologize. So, 42-year-old guy. He presents with atrial fibrillation. Remember that rhythm, very common rhythm in the population. Top chamber does its own thing, becomes very rapid. It's an incidental finding, really. He was feeling a little bit fatigued, goes to see his GP. He then has a cardioversion to get him back into normal rhythm. He has an echo which shows some mild impairment of function. Now, remarkably, somebody took a family history. But a family history in a busy clinic is usually, anybody in the family with heart disease? Nope. Okay, next patient. Family history here was father had atrial fibrillation. Father had a pacemaker. This was upgraded to what we call cardiac resynchronization therapy, implying that his left ventricle was not working properly. And then he died in his 60s. His grandfather, atrial fibrillation, pacemaker, died in 60s. This is an electrocardiogram. It shows atrial fibrillation, sort of irregular rhythm. But the ECG, the pattern on the ECG is not normal. And when he had a 24-hour tape, you see these are normal beats, and you see these beats are a different shape. This is what we call non-sustained, because it's only a short run, of ventricular tachycardia. His ventricle is twitchy for some reason. What's that got to do with atrial fibrillation? And the echocardiogram, this is the left ventricle, the main pumping chamber of the heart. This is the picture we take from the apex, if any of you have had an echocardiogram. For some reason, we always turn it upside down and back to front. I don't know why, but we do. So these are the two ventricles. These are the two atria. The atria are a little big. We do an MRI, because we can. And it shows similar sort of thing, no scarring in the muscle at all. So this morning, for those of you in the session this morning, I made this point about what happens to you often depends upon which box you're put into, what label you get. So if people go down the conventional route of heart failure management is all about the ejection fraction, that magic number. How bad is the pump function? And the kind of treatment you get depends on the number that you have. And that's often where it stops. But with what one of my colleagues, one of my erstwhile colleagues in Italy, Claudio Rapezzi, used to call the cardiomyopathy mindset. It's, hang on a minute, this is not just about an ejection fraction. This is a relatively young guy who's got a family history of atrial fibrillation pacemakers. He's got a twitchy ventricle. And the question is, why? And the why, we briefly touched on this morning, that gobbledygook means he's got a variation in a gene called lamin. And the reason that is important is because that can cause sudden cardiac death. But this is hidden in the noise of heart failure trials. It's there, but because the numbers are relatively small, you don't see the signal. Here's another one. Okay, so it's a 24-year-old guy. Again, incidental diagnosis. Someone feels his pulse. It's very irregular. And then that sets in train a whole legacy for this poor guy, where he's having biopsies and angiograms and electrophysiology studies. He feels fine. He says, just please leave me alone. But this is an ECG. He's got too many spikes. You know, his heart rate here is, whatever, 100 and something. But it's mostly because a third of his beats are what we call ectopic beats. His heart's on fire. It's coming from the atrium, the ventricle. It's coming from all over the place. And when you have this number of extra beats, that can affect the pump function. So this is an MI with 2 ventricles, 2 atria. This heart is very bad. So what's the way of treating this? So try to get rid of the arrhythmia, yes. Give him the drugs, yes. But the question is, why does this 24-year-old guy have such a twitchy heart? And we do genetic testing, and the gobbledygook here is that he's got this variant in what's called a sodium channel. The point is that this is a fantastic report because it says, okay, so this has been described in families with dilated cardiomyopathy and ventricular arrhythmias and severe systolic dysfunction, diagnosed before the age of 30. And this tells you this is the gain of function, which means it's making the protein overactive, and we can block that potentially with a drug. A really old drug called quinidine. So we put him on quinidine. Remember, this guy, a third of his beats, tens of thousands of beats were extra beats. And he goes down to 3 extra beats, and his ejection fraction increases to 62%. So for me, this is the ultimate in personalised medicine. You've defined what the cause is, and you've tailored your therapy to the patient. But I realise I'm not going to change things just simply by shouting at people. If we want this to become embedded in routine practice, we've got to show a number of things. One of those is that, is it real? So I'm showing you a few cases. My clinic is full of people with the rare and the wonderful. But is it just my clinic that's like that? If you go to a clinic in any GGH, would you see the same kind of thing? And I think we've got to prove that if you want to change the whole paradigm of the way in which we do things. In dilated cardiomyopathy is about a third of people with heart failure. If you do genetic testing, you'll find something in about 25% of people. If you've already got a family history, you've got a 1 in 2 chance of finding something. And this keeps being repeated. So if you have a diagnosis of dilated cardiomyopathy, there's a very high chance of finding a genetic mutation. If you go looking, I always say rare things are rare if you don't look for them. So this is a poster chart, and I'll come back to this a couple of times today. So this is a condition called amyloidosis. It's where you get deposition of abnormal proteins inside the heart. And if you take people with this so-called diagnosis of HFpEF, so the heart is, you've got heart failure, the ejection fraction is within the normal range, and if you're over the age of about 50 or 60, 13% of people. Okay, so maybe we're starting to show this stuff is there, but so what? Because I've already told you there's a ton of things that we can do in cardiology. Well, one of the things that understanding the underlying cause allows you to do is to stratify populations into high risk, low risk, so you can try to do something about it. Skip that one. No, come back to that one. This is a study from North Italy showing that you can take patients and stratify them by how bad their heart is on an echo or by their genotype, and the genotype wins, at least in terms of predicting sudden cardiac death. But the real actionability is the development of drugs which might treat the underlying cause for the cardiomyopathy. This is the poster child, this is amyloidosis. So one cause for amyloidosis is that we produce this protein from our liver called transthyretin. And as people age, for some reason, some of them, that protein breaks up, circulates around the body, and then deposits again inside the heart. It makes the heart thick and stiff. And we now have drugs that can stabilize that protein, stop it from breaking. And we have randomized trials showing that you can, in a population with an average age of 75, reduce their mortality by a third and slow disease progression, which is probably more important when you're 75 because you want to try and maintain quality of life. The box is now open. I said, my conflict of interest and my declaration of interest slide at the beginning was because all those companies are trying to get into the space of managing cardiomyopathies. If you haven't already heard, there are drugs that have already been trialed. A drug called Mavacamten is coming up a lot. There's another one called Aficamten, which is going through trials at the moment, in people with hypertrophic cardiomyopathy that have obstruction. This was originally developed through an understanding of the mechanism of the disease in patients with HCM, and what it does is it makes you feel better, reduces the obstruction, reduces the strain on the heart muscle. Where there are now billions being invested is saying, okay, so we've got genetic disease, can we modify the abnormal gene, at least inside the heart? And I'll talk more about this in the last talk of today, but this is now being investigated. For example, some people who have a genetic mutation, it means that they don't produce enough of a particular protein. So what if we could get a normal copy of the gene inside that cell to make that protein and raise the levels again and restore function in the cell? How do you get the gene? That's the challenge. How do you get it to the heart? Well, one way is to package it up in a safe virus, and that virus then travels around the body, gets into the heart muscle, and then it releases a bit of the normal gene, which then starts producing the protein. Sometimes this is referred to as gene replacement therapy. Science fiction? Just been done. First patient dosed in the United States. We'll see. So I think in terms of personalised medicine, I think we have got a lot of effective treatments for cardiac disease. And you'll be familiar with them, ACE inhibitors, the prils, statins, beta blockers, devices like defibrillators. But I think we're very rapidly moving to a whole new landscape of different kinds of treatments. I haven't touched on these, things like inflammation in the heart. Again, huge interest in that and trying to change that. That's what I think is personalised medicine. And this is a slide I've been using for a very long time in a theoretical context. But now I think it's becoming a reality. I'll stop there.
Professor Elliott, thank you for that. All of that seems quite far away, doesn't it? Even though, in terms of reality, for us here in the UK. I was just thinking last year when we sat at the conference and we were very excited about, about Mavacamten. So the first targeted medicine, really, for a cardiomyopathy. I just wondered if you could start by giving us a little update about how that's going and how close it is to actually becoming a reality for us, rather than something that we hear about and talk about but actually don't see.
So I will, but just to your opening line, is it a reality?
Mm-hmm.
I've got members of the trials team from Barts here.
Yes, I know, yeah.
How many trials are we doing at the moment in cardiomyopathy, people? 10 cardiomyopathy trials. 10?
I know, it's amazing.
10
I know.
cardiomyopathy trials. I mean, these poor people are fed up with cardiomyopathy. I was wondering, a few years ago, that was not the case.
Not just for HoCM?
No, DCM, I mean, and will be for one form of sort of twitchy hearts. Yeah, no, it's across the piece.
Oh, okay. So
No.
is that with Mavacamten?
I'm coming on to that. But so there's a if it works, the question is whether it's going to work, and if it does work, I think next year, the year after, you're going to start seeing this stuff, at least in theory, being used in clinical practice. But Mavacamten is a useful illustration of what is possible, but also some of the challenges we're going to face.
Yeah.
So Mavacamten is a drug which has been trialled with a positive study called the Explorer trial. This is a drug which, in a very simplistic way, a bit like beta blockers and calcium antagonists, reduces the force of contraction of the heart. It's been used in people with hypertrophic cardiomyopathy that have obstruction to the outflow. In a randomized trial, it's been shown to reduce symptoms, improve exercise tolerance, reduce markers in the blood which show you the heart's under strain, something called BNP, troponin. And interestingly, that's in people who are already receiving beta blockers, calcium antagonists. So it's over on top of what's already been given. The drug has been approved in the United States, been approved in Europe, and now it's approved in the UK. About 3 months ago, something like that. So what that means is that within a 90-day window, trusts or nominated trusts are supposed to have it in formulary.
Yeah.
So that's the 5th of December, I think. But
There's always a but.
the but is that it's quite a complicated drug to administer. So you have to do echoes every 4 weeks as you're increasing the dose. Now, waiting times for echoes. There were 10,000 people waiting in London for an echo, so Jerry told me. Some trusts it's 6 months, some trusts it's 12 months for an echo. So what this means is that we're having to very rapidly create an entirely new pathway for patients who are going to be receiving Mavacamten. But that's a good thing. Because what it means now is we're effectively going to fast track. Remember that we had a conversation in the previous one about the fact that it took that poor chap 6 months to get from his first diagnosis to getting his first dose of beta blocker. That's not the way to do things, but we do it all the time with people with obstruction. It probably takes a couple of years from first referral to seeing you, to trying beta blockers, trying diazepyramide. Then it doesn't work, and then we think about alcohol ablation and surgery. That whole pathway takes a very long time. What this is going to do is to accelerate that pathway. So, talking locally at Barts, we're going to set up a special clinic with nurse-led up titration. We'll get the echo sorted out. There's a few other steps we have to sort out. But my hope is that by the spring, it will be up and running.
Okay.
So I think Mavacamten is here, and it's also going to drive, I think, a beneficial change in practice.
Yeah, I'll come back to that later. So Mavacamten specifically was for obstruction.
Yeah.
But it's also starting now to be shown to be effective in non-obstructive disease, isn't it? Can you give us a little update on that?
Yeah. So I said in a simplistic way, it just reduces the force of contraction. It actually does a lot more than that. So one of the holy grails of therapy in cardiology is to find drugs which genuinely make the heart muscle relax, make it less stiff. And there are drugs which do that a little bit, but not much. This drug really seems to do that. And so there's a lot of interest now in reducing the stiffness of hypertrophic hearts, but maybe other hearts. And there are now ongoing trials. Some of the trials we've been talking about are in non-obstructive disease. It's a mixed bag, non-obstructive hypertrophic cardiomyopathy. So I think the response is going to be equally mixed. And showing benefit, my prediction, I got it wrong with Mavacamten, but my prediction would be that's also going to be harder to show. But we'll know very soon. the trials will, by the middle of next year, we'll know at least about one of the trials.
Okay.
Now, if that works, and I genuinely hope it does work, it means that this accelerated pathway, because the drug is going to be the same drug and you're going to have to do the same safety thing with echo, that means everybody with hypertrophic cardiomyopathy that goes on that. So that we don't we don't want to think about that just yet. We'll wait and see what the trial shows. But it may mean we have to change the entire pathway for at least HoCM.
Yet again this year, you've touched on a question I'm going to ask later. But
You've got a lot of questions for later, Libby. So
you're being quite chatty this year. I think there's more than water in there.
I think there might be. Yeah.
So just finally on the update section, so Tafamidis.
Yeah.
So it's available now in Scotland.
Yep.
Do you know when we're going to get it in England?
The NICE meeting is on the 6th of February, I think. Well, I was going to say it seems inconceivable that they would turn it down for England. You're really going to have people are going to have to cross the border to get their Tafamidis. But strange things do happen. But I think what it means is that the price is right.
Yeah, okay.
Because that was really what was holding Tafamidis back.
Yeah.
Which
was true of Mavacamten as well, isn't it?
Well, it could have been.
They're expensive drugs,
It could have been. They are expensive drugs. So Mavacamten in the US costs, it's about $90,000 a year.
I paid 80,000.
To you? And we, as a community, we were saying, not just in the UK, but in Europe, if you come and price it at that amount in Europe, it ain't going to get prescribed. Because there's just too many people with hypertrophic cardiomyopathy for that. So we're not allowed to know what it is that they've settled on, but it must be substantially less than that. And Tafamidis, they didn't compromise.
We're not allowed to know, are we?
No. It's because it's a confidential negotiation between NHS England and companies.
Okay.
But you can guess.
Okay.
So the threshold for acceptance, the acceptance for what's called a quality threshold is 30,000 a year. So if it's got across the NICE line, it means it's probably that or less. So I think Mavacamten, we're being told, and I'm not sure we should be being told, it's about £1,000 a month. Yeah. Yeah.
So, finishing off with those updates, just to pick your brains a little bit more. So we've been talking about precision diagnoses, and historically in cardiomyopathies we've talked about umbrella terms, haven't we?
Yep. So
HCM, DCM is an umbrella term under which there are many different diseases. So as we're getting these more precise diagnoses and precise medicines, do you think that, obviously there needs a more nuanced approach so that people people sort of get diagnosed, don't they, and they get given this umbrella term and then they don't go any further with it. They land at that term and then that's it and nobody investigates. So do you think there's a risk that even though the medicine is progressing to more and more precise medicine, that actually there'll still be a proportion of people who will be at their DGH and they'll be told, we've looked at your scan, we've described what we can see, you've got a thick heart, you've got a baggy heart, whatever, here's your beta blocker, and they actually then don't get any further down that line. Do you think there's a real risk of that happening?
Yeah, I mean, I would say that's the current state of the art, is that baggy heart or hypertrophic heart. And what runs through the 2023 ESC guidelines for cardiomyopathy is an attempt to move that concept on towards a more etiology-based approach. It is quite challenging. Actually, I think the conversation I was having with John, and he said the trouble with these labels is that people almost define themselves by that label.
Yeah.
I mean, you define yourself as a patient. What am I? I'm a patient with hypertrophic cardiomyopathy, or I'm a patient with dilated cardiomyopathy. Cardiologists do it. I'm an expert in hypertrophic cardiomyopathy, and then we come along and say, yes, but we really don't think you should use those terms anymore. It does have a consequence. So it's an evolution. Can I just, I think I have have we got a reserved slide? Can you put my slides back up again? Sorry. I'm not even sure it's there. So what I try to do, it's the same with Wankaski as well. It's when you sit, if you see a lot of people with these conditions, it isn't a problem in the clinic. Mm-hmm. I don't sit there agonizing over, is this hypertrophic or is this, oh, fantastic, thank you. I think I took it out. Oh. No, I've turned it off. So to give you an example, we had a discussion in the previous session about this new entity, we used to talk about arrhythmogenic cardiomyopathy. And we said, no, we're not going to use that term anymore. Mm. What we would like people to say is that this is a 33-year-old man with a high burden of ventricular. Go right to the end? Or can I do it? With a high burden of ectopy, a lot of myocardial scar. Let me just see if I can find it. I'll put it in. I'll be testing on you on this later. No, I didn't put it in, sorry. But thanks for your help. What I try to create in my letter is a narrative diagnosis. So 32-year-old, family history of sudden cardiac death. Mm-hmm. He's got a high burden of extra beats. His imaging shows that the ejection fraction is 45%. He's got a high burden he's got a lot of scar on his MRI. Mm-hmm. We've done a genetic test, and this is a cardiomyopathy related to a desmoplakin mutation. What does this mean? We know that desmoplakin mutations are potentially associated with high risk of sudden cardiac death. Based upon the scar and the ejection fraction and the high burden, we recommend a defibrillator. Mm. Now that's about that much text, but people say, yeah, but what cardiomyopathy does he have?
I was just going to say, actually, I was going to pick you up on that. So that's you.
Yeah.
So you do that.
Yeah.
And you're at a specialist centre.
Yeah.
How many cardiologists who are not in specialist centres go that extra mile?
I think it's changing quite quickly.
Okay.
I think it's changing
so you
quite
wouldn't
quickly.
advocate then that people are referred to specialist centres? Is that even possible? Is that doable?
It's a slightly different. I mean, first of all, it isn't possible. Mm. So it is. So our waiting time my waiting time for a new patient is 48 weeks. For a follow-up appointment, it's pushing 18 months. Now that means we need to. We're having a lot of discussions at the moment about how we do this. Mm. Do we really need to follow everybody forever?
Yeah.
We can't.
Yeah.
But equally, there's so much cardiomyopathy out there that it's not possible for everybody to go to a specialist centre. So how do we deal with that? We can create more centres, but I think one of the things we're talking about at the moment is having this tier 1, tier 2 approach. So you create networks. Mm. You have perfectly competent district general cardiologists who take a special interest, mm-hmm. and a lot of this stuff could be done there.
Okay.
So it's about defining the criteria, the indications for referral into a specialist centre.
Okay.
It's a word which is being used a lot, I'm not sure it's the appropriate word, but democratisation. It's making this mainstream. So rather than saying this all has to be ultra-specialist, it just becomes everyday business. And when it's difficult, you send it to a centre.
Yeah. That is kind of a two-tier system, though, isn't it? So
two tiers in the sense, but not necessarily second class.
No, I don't mean second class at all. No, I just mean that actually, that there'll be a level of sort of complex cardiomyopathies and common or garden cardiomyopathy. Yeah. Is there a grey area in the middle where people might
always. But then I think that's what the specialist centres are for, to help with the grey areas. Okay. So I think that's what the job of the centre is.
So, you mentioned about the world of cancer.
Yeah.
Very, very precise medicine, very precise classifications. And I think, as we move towards more precise, personalised medicine in cardiomyopathies, is there a need for not a new classification, but a new way? So I think you've written a paper, haven't you, about a new system that's kind of based around how we classify cancers. And is that the way, is that what we're going to be looking at in the future? So like when you have a cancer, it's staged with, you know, and you end up with lines of letters and numbers. Is that going to be what cardiomyopathy is about? And what do you think the challenges are of implementing that change? And essentially, who's going to inform the patient? Because if the patient wants to know, I've got hypertrophic, I've got dilated, well, actually, you've got, you know, you know.
Yeah.
How does that work?
So,
will it work?
So that's, don't tell anyone, but that's what we're trying to push the world towards. These labels, dilated cardiomyopathy, hypertrophic, they still have value.
Because that's still the starting point, isn't it? In the new ESC guidelines, they do recommend starting at that point.
But those lovely coloured figures that I've shown you are dripping with blood.
Oh, are they?
Yeah. Because the debates were pretty fiery about this particular issue. And it's why we go out of our way not to use the word classification. Phenotype-based, blah, 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 blah. So we're saying that the phenotype, which is...
That's the describe what you see bit,
Describe what you see, but describe what you see in a broader context. So it's not just about the ejection fraction or the wall thickness, but it's also about the family history and the ectopy and the heart block and all the rest of it. So it's a very deliberate nudge towards what you're describing. So we were talking about desmoplakin-related cardiomyopathy, or we might talk about beta-myosin heavy chain cardiomyopathy. Because we already know that if you have a mutation in beta-myosin heavy chain, you might get a thick heart, you might get a dilated heart.
Yes,
There are all sorts of caveats to that. One of the caveats is that it's very hard to come up with a universal system for classification that serves everybody's purpose.
Okay. And yet it does happen in cancer, doesn't it?
It does sort of happen in cancer, but it depends what you want. If you want a classification for, say, should this person have a defibrillator, or should this person have an SGLT2 inhibitor, dapagliflozin, then actually it's largely about function and the morphology. If it's, does this person need genetic testing, or does this person need a gene-guided therapy, then there's greater emphasis on the molecular diagnosis. So I think we're going to end up with a mixed economy in a way in terms of classification. But yes, the short answer to your question is the destination is a more molecular-based approach to disease description.
And how's that going?
It's going well. If I could show you the slide, just show you where it's going. No, I think I think it is genuinely going very well. And again, what will drive change is therapeutic innovation. Tell me when it makes a difference. Tell me when it makes a difference. If knowing a genotype makes a difference, then people will start talking about beta-myosin heavy chain, and they'll start talking about desmoplakin-related disease, because that word then leads to a treatment.
Yeah. Okay. I have another question, but I won't ask it. So, just to round up this session, the title of this was Personalised Medicine. Are we there yet?
Was it?
Yes, Perry, it was.
Oh, was it?
Are we there yet?
Are we there yet? Yes, we are.
Okay.
But without getting too Churchillian about it, it's the end of the beginning.
Okay. And possibly in London.
What, in London?
Yeah. Like maybe only at specialist centres.
No.
Okay.
No. But the specialist centre is not just in London, you know.
Yes. Whoops. Thank you for answering those questions. It's really great to hear that. And it's great to see all of these new advances, I think, and all of the new trials that are going on. It's fantastic. So,
I mean, genuinely, it feels so different. It feels, now, 5 years' time, if I hadn't taken early retirement, I might come back and none of the trials would have worked. And we'll be saying, well, we've got Mavacamten, we still can't get the echoes. It might all be very different, but
and we've all moved to America.
Yeah, no, I don't think so. If some of this works, that moves us forward so much.
Yeah.
And the fact that pharma industry is not daft. For them to go out and spend $1 billion on the development of a new gene therapy means that they believe that this could work.
Yeah.
I mean, we've been there before, but
Yes, quite. So I hope all of you have been on the app asking your questions. Guillaume, maybe we could go to a question in the room first. So if anyone's got a question for Perry.
Fantastic talk, thank you so much. I was just in the previous session, not in here, next door, about shared decision making.
Right.
And then listening to this about personalised medicine. Have you got any hints and tips about how patients can help with personalised medicine and what we can do, because these two things are coming together?
I think it's an essential component of it, because I don't think you can do this kind of medicine without buy-in and understanding of the individual who's going to receive it. We had a discussion in the previous session about communication between healthcare practitioners and patients, families, individuals. And I think if I was to summarise it, I would say it was pretty rubbish a lot of the time. Because it's not very human. It doesn't sort of acknowledge the fact there's often not a right answer or a wrong answer, but there's an answer which emerges through discussion and understanding and a transmission of information for that individual. And some of these therapies are going to be complicated. So, for example, gene replacement therapy, it requires you to have cardiac biopsies at the moment. It requires immunosuppression. There are going to be a lot of unknowns about gene therapy. Some people are not going to be able to take it. Some people may get reactions to it. Some people, there's a sort of a gene therapy plus, which I'll talk about, which is called gene editing, where you actually redesign the underlying genetic code to take away the abnormality in the gene. Could you get what we call off-target effects? Could that become a transmissible change? So there's going to be a lot of things to talk about with gene therapy and some of these other therapies. So shared decision-making, I think, whatever we call that process, involvement of the individual who's going to receive this is essential.
Perry, I've just got a question from the app.
Yeah.
Okay. So stem cells.
Sorry.
It's the most popular question.
Yeah.
So can stem cells be used to repair heart muscle?
No.
Okay.
Want me to give you a longer answer? People have been trying this for as long as I've been on God's earth, I think. And the trials are all pretty much the same. So you can increase ejection fractions by about 5%. Mm-hmm. So the basic idea is that you've got a damaged heart, the heart's not capable of repairing itself other than through scarring. So if you can get these special cells inside the heart which can turn themselves into heart muscle cells, then that will make the heart beat in a more effective way. In the past I used to use the analogy, which I haven't used for quite a while, but thank you for giving me the opportunity to use it again, it's like taking a wet piece of paper, taking a handful of sand, throwing it at the paper, a few of the grains stick, and you expect it to have miraculous effects.
Very good analogy.
Do you like that?
I do like it.
Do you like that?
Yeah, I do.
Now, what I'm saying here, I could easily get into a fight with some of my colleagues over this, but it's maybe I will be proved wrong someday, but it would go through this same process of stem cell, try the stem cell, try the stem cell, try the stem cell. Definition of madness is doing the same thing all the time and expecting a different result. Exactly. So that's why I give such an unequivocal, bullish answer. It's not. For me, it's not the answer.
We should stop now. Not we should stop.
Can I just ask a clarification question? So the drugs that you were talking about, do they just deal with the mechanics of the heart muscle, or would they deal with, and I'm sorry to reference this again because I know it in the previous session, for example, lamin, which is an electrical dysfunction. So are any of those drugs, my question is, would they deal with lamin, would they help, or is it just purely the mechanics of the other issues, or the heart conditions that you spoke about?
Yeah, so with the drug Mavacamten, so that was originally a very bespoke mechanism. I think it's in my next talk, but one of the problems with some of the mutations that cause hypertrophic cardiomyopathy is they make the different proteins that slide across each other inside the heart to cause it to contract, to hang on to each other for too long. And that makes the heart thicken in response. So all Mavacamten does is to reduce that interaction.
So are any of those being developed that would help with lamin?
So I'm getting there. The concept of Mavacamten then moved on from that very specific genetic mechanism to giving it to everybody with hypertrophic cardiomyopathy. And at the moment, that seems to be paying off. So it seems to be a more general mechanical effect. Lamin is going to be the same approach. What is the underlying molecular mechanism by which you get all the features of laminopathy? And can we target that? There is a trial that's actually completed in lamin, which unfortunately was negative. Yeah. And it ended up with Pfizer, but it started off with another company, which I can't remember now. But it was basically stopped because of futility. It showed no benefit. And that paper's now with the journal. Well, lamin is definitely a target because lamin, amongst all the other dilated cardiomyopathy phenotypes, probably doesn't respond so well to conventional medication. It's certainly something the companies are looking at, but because of the genetics are quite complicated with lamin, it's not quite so tractable as some of these other diseases. But it's definitely on the hit list.
Okay, I just wanted to ask that
Yeah.
question. Thank you.
What's the future then for getting drugs, etc., if the NHS is in Mr. time is 18 months on
Yeah.
consultations, and more importantly, the work caps, etc., do you have to get private?
No, it's a great question. It's quite a complicated issue. So, how do we, if we're entering a new era of very expensive therapies, how do we prioritise? Is a big question. I had my big political rant before lunch, but I think this needs to be much more overt. Is how do we decide who gets these drugs? Because one of the dangers, for example, gene therapies, they could be $1 million a pop. Because it's one therapy for a lifetime. Right. So the companies are going to want to recoup their investment on that one dose. In some healthcare systems, that may mean it's only the rich that can get it. Fortunately, we don't live in that kind of system, but we do. There is still a certain element of lottery as to what gets funded and what doesn't get funded. We'll have to see. I mean, you saw, was it yesterday? The first gene editing, this technique I talked about, where you actually modify the underlying genetic code for sickle cell anemia. It's just been licensed. We're the first country in the world to do that. So we can do it when we want to and when we think we can afford it. But the process of selection, it probably needs to be a bit more overt, because some of the questions might be quite tricky.
Perry, I'm going to ask you another question from the app, if I may. So should treatment for cardiomyopathy be tailored to the individual based on their specific gene variant, age or gender? And I think the gender bit is quite interesting in that question, because we still don't know with drugs that we've got now how they affect men and women differently, do we? So what are your thoughts on that?
Yeah, Mavacamten seems to be equally effective in men and women from the sub-studies. The answer to that question, of course, is yes. And management of a disease, even with all these new therapies, is not just going to be about new drugs. It's going to be about managing all the risk factors. So in hypertrophic cardiomyopathy, we know that having hypertension, for example, or having sleep apnea, these modify the degree of hypertrophy you develop. So I think the personalised element is, yes, the molecule, but it's also about all the other stuff which is peculiar to that person. Whether you factor in gender into that is difficult to know, because it's, does it mean that you're going to give it to the boys and not the girls? Or vice versa?
Yeah.
I don't think we're going to get to that situation.
Okay.
Unless there's really clear evidence that okay, but it's not going to, I don't think it's going to pan out that way.
Okay. Any more questions from the room?
Just referring to the long waiting lists that you were talking about earlier.
Yeah.
Practically, how do we get to a point in a speedy way, of reviewing someone's drugs that they're currently on, personalising as much as possible, if it's difficult to access your specialist or even get into a specialist? Or is there a way, I was interested that you guys are working out new ways of working around these new drugs. Is there any, are people looking at how they can do that across the board with people, not just with new drugs coming out, but just with what they have?
That's a great question. So, those of you who heard my political speech last time, I could launch into it again. No. It's because what you're, I will repeat some of what I said before. This is a question for us all. What kind of healthcare system do we want? So, if we want a healthcare system which gives you quick answers, quick access to healthcare professionals, it ain't what we got at the moment. So if we want to achieve that, how do we do that? How much is it going to cost? How are we going to pay for it? So I'm part of the decision making as well, because it affects us all. We can all get sick. But I think we're reaching that point. I think in fact we probably reached it in 1963. But we've reached the point where our healthcare system, as it's running at the moment, is not sustainable. So we've got to have a really open, intelligent debate about what it is that we want, and is the current way of funding it and designing it the way of delivering what we have ambitions for. I mean, I'm sure you're all seeing it already. I mean, in a way, the system is adapting. So how many of you, I don't know, anybody been to see a GP privately recently? No? I mean, a lot of my patients are seeing GPs privately now because they can't get access to their GP. I'm very fortunate. I've got a fantastic general practice. But it's a sort of quasi-private polyclinic model where everything is in one place. If you need urea syringe, don't need to go and see your GP. You can pay 40 quid and get it done. That's one way of doing it. But if we want it to be the traditional 1948 model, then you probably need a Swedish solution, which is 60% tax. Your choice, my people. So it's a great, I know I'm not answering your question, but it's, what we want better, don't we? We all want better.
Yes, and to your point, what are we willing to do?
Yeah.
And it is a conversation, isn't it?
Yeah, it is.
But it occurs to me that when we see our GP and we say there's been an episode, but you've got to wait another 18 months to see your specialist to discuss, meanwhile you're in the hospital and they're throwing more drugs at you to say, just take this and take that. And there's a kind of disconnect.
There is.
Could be quite...
And there's lots of experiments which have been done in other countries, so we can learn from others' experience. So in some countries you don't need to go via a GP. Is that a good thing or a bad thing? And of course the answer is it can be both. So in Germany, I think I'm still right in saying this, that you can just go directly to a cardiologist if you want to. So you go along the high street in Hamburg and Herr Dr. Cardiologist, Herr Dr. Cardiologist, that's great. But Herr Doctor may have only seen one person with hypertrophic cardiomyopathy in his entire career. So is that the way forward? Perhaps not. But it's learning from what has and hasn't worked elsewhere, I think.
Barry, can I ask, talking about the change of, you talked this morning about not being able to sort of, as a society, criticise the NHS.
Yeah.
And it's you described it as like a religious institution. And I think that really is a huge part of the problem. But people want the change. They want to have the discussion. Mm-hmm. How can we, as people with the disease, or we as a charity, try to move that discussion forward? And can we, or is it something that's completely out of our hands and with the politicians?
Yeah, that's a great question. I think, so obviously as an organisation, as individuals, we can't engineer change at that scale. But, for example, and I'm thinking on my feet now.
Good.
Why not have an open forum or a discussion on this very issue? I mean, it can be, the excuse is cardiomyopathy, but of course it's a generic question, isn't it? And if Cardiomyopathy UK does that, and if Cancer Research UK does that, and if I think actually people are ready for your point, I think people are ready for the discussion now.
Yeah, I agree, yeah.
So I think it's I said, again, sorry, in the previous group, I think we need to help our politicians do this.
Yeah, yeah. Oh, no! Oh, my God, no. Well, we've got the president of the charity and the chair of the board of the trustees in the room.
There we are.
So can we do it?
We can do it.
We'll do it. Yeah.
Yep.
Okay.
And maybe, I mean, again, to be discussing it, but maybe do it as a partnership with other charities, because then it sort of amplifies your impact in a way. Yeah, yeah.
Other cardiac charities.
We've reached that time, I think.
Other charities.
Yeah.
Other cardiac.
Sorry,
other cardiac charities.
Thinking along these lines?
Yeah.
I've no idea.
No, I mean, should we liaise with other cardiac charities or other charities in general?
I think I wouldn't just do cardiac charities, because I think it's a general issue. I don't think it's just.
Yeah.
I mean, we can highlight those particular issues relative to cardiomyopathy, but it's much more existential than that. It's much more about the healthcare system generally.
Yeah. Power in numbers as well.
Yeah.
And then ask all of us to write to IG.
Absolutely,
MPs,
yeah,
to
yeah.
ask them to attend, because MPs respond to letters in their inboxes.
Yes, yeah.
This feels like the beginning of a revolution.
It's what we need, Perrin. It's what we need. And you're leading it, Martin.
Yeah. Yeah, absolutely. Absolutely.
Martin.
Yeah, thanks. I wonder if I could ask you, personalisation, a key part of that, I assume, is the data coming from implants, because more and more people are getting implants. The question I wanted to ask is, who owns that data? It's obviously not the patient, and I assume the hospital doesn't, it's probably the medical device company. So how much of that data is fed back? And if you get true personalisation, shouldn't the patient take control of his own data in total and decide who has access to it?
Yeah, so it's not the company that owns it. Absolutely not the company that owns it.
Well, I had to sign a form to Abbott to give them...
Were you part of a trial?
They didn't tell me I was. It was an ICD.
Yeah. So, now, I mean, there's data on the safety of the device, so on technical data, but there should be nothing identifiable about you and your condition or anything else like that.
Yeah.
I think we're nearly out of time, Perry, but just one more question. Really nice question, actually. What hope is there for personalised medicine in the face of a polygenic diagnosis?
Who answered? Is that online?
Yes.
Is that Dr. Ware?
No, it's not. No. No, it's not.
Are you sure?
I'm very sure.
What's his nom de plume? What does he use?
It's unidentifiable.
Okay, all right.
I'm not Dr. Who. I'm a stooge.
A plant. So that's a great question. So the idea here is that genetic disease is a spectrum. So you can get a single spelling mistake in a gene and get a disease, or you can have lots of small hits in a gene which by themselves don't have a huge effect, but you put them all together and then you cross the threshold for getting a disease, and that's what's being referred to as polygenic effect. And a lot of diseases are often more polygenic than what we call monogenic. So coronary disease, for example, in the population, or cholesterol levels may be polygenic. Everybody's hoping, we're developing scores which allow you to sort of estimate someone's risk according to the number of hits they've got in their genome. At the moment, it's not proving to be very helpful. But if we move forward 10 years, the AI question, you've got to integrate really quite a complex data set between a polygenic effect, a monogenic effect, whether you smoke, whether you're male, whether you're female. That might be where AI can help us as a tool. But if we're going to create those kind of models, and they are being created, it's something which needs to be properly validated and tested in the clinic to see if it actually works in the real life. Polygenic effects are also quite location and specific to a genetic background. So what happens in yeah, Cornwall is not necessarily what happens in Botswana, because the polygenic risk score is likely to be very different. So you know, we can look at ancestral components to inheritance, but it's a complex area, and lots of people are trying to get this into practice for the prediction of coronary risk. We'll see.
One last question.
So I've got, I think, 3 chronic health conditions. So I think my question, I'm guessing like comorbidities. So
Yeah.
how are services working together in terms of personalised
Yeah.
medicine and
Again, fantastic question. So the question was about comorbidities. You know, lots of people have got more than one condition.
Mm-hmm.
And to get an optimal health outcome, you want to manage all of those things. Is it joined up? You tell me.
Not in my experience, no.
No, it's not really. Again, another thought, again, given that we're being revolutionary here today, and I sort of come back to the question you asked about sort of whose data is it? In a way, who should be coordinating the care for N=1? Maybe part of the new contract that we're going to negotiate between the healthcare system and the people is that maybe people take on more of that responsibility themselves.
Mm-hmm.
I'm not sure it's the best example, but have you heard of PIFU?
No.
PIFU? Patient-initiated follow-up. Yeah? And there are different models of patient-initiated follow-up. But you know, why should you come every 6 months? Just because it's more convenient for the system to do it that way. Why don't you come when you need to come? And if you know your health condition and you know it's time you had a test or something, well, you book your appointment. You know, why, if you're in the system and you're managing your own blood pressure at home, and that's AI, wearables, you know, we can probably be much more active in the management of our own conditions rather than asking a system to do it, which can't really do it very well.
I think my response to that would be, my experience has been difficult. I've been very active in my own care, but to give you an example, I have myotonic dystrophy type 2,
right.
And for myotonia, mexiletine is thought to be quite helpful.
You can't get it.
But I've got an ICD and HoCM. My consultant has said potentially could use it, but I need to speak to my neurology team to put certain benchmarks in place, and despite me chasing both cardiology and neurology, it's just never come to fruition.
Yeah.
So I take what you're saying, but...
So your homework is to conceive of a system. Because I don't have the answer to that.
No.
I don't any of us have the answer to that. But what kind of system would allow those conversations to take place? I mean, you know, why do you need to go to visit somewhere for that to happen, for example? I don't know, but your experience is, particularly when you have a series of complex conditions, where often there isn't actually a genuine answer to the question, but really what you want is 3 people or 2 people to get together and just have a chat and say, we think you should do this. And it's how do we create that space for those conversations to take place.
Fantastic, thank you. Thank you so much, Perry, for that. Really fantastic session. You may clap.